Hi, everybody. I'd like to welcome you to the NYU Langone Orthopedics webinar series. This is the orthopedic trauma section, and we're going to be talking about ankle fractures, state of the art. I'd like to thank everybody for coming and taking the time. What we're going to do is we're going to have a series of lectures that are about 10 minutes apiece. And then once those are done, we'll have time at the end to answer any questions that you guys have and to go over some cases if there's still time. So with that, we're going to start it off with Dr. Milan Patel. He's going to get started with the posterior malleolus. When do I need to fix it?
Sorry, can you guys hear me? Lost my ability to unmute there. I'm not seeing my control screen. All right, there we go. All right, so sorry about that. I'm going to talk about posterior malleolar fractures. When do we need to fix them? All right, so posterior malleolar fractures are very common. They're found in anywhere from 7 to 44% of rotational ankle injuries. They can also occur in isolation or as a component of a pilon fracture or a tibial shaft fracture. In any case, the posterior malleolus is very important for tibio-talar load transfer and also for posterior talar and rotatory ankle stability. The management of posterior malleolus fractures is a little controversial. Traditionally, the treatment has always been based on size of the fragment, with 20 or 25% being the classic rule, but more recently the trend has been towards more aggressive fixation of these injuries. In terms of anatomy, stability of the ankle primarily comes from the shape of the tibio-talar joint, the lateral buttressing effect of the fibula, and of course the syndesmotic ligaments. With the posterior malleolus, the PITFL and the transverse ligament are both attachment points at the posterior malleolus, and these are very important as they span across the posterior ankle and provide basically a labrum about the posterior ankle joint, which prevents posterior tibial translation. And of course, you have your musculotendinous units, the peroneals, the flexors, and the extensors that also contribute to dynamic stability. So posterior malleolar fractures are very significant. More recent data has shown that the posterior malleolus is a huge contribution to the overall surface area of the joint, and that's probably due to the rectangular profile of the plafond. So losing anywhere from 33 to 50% of the posterior malleolus results in a 65 to 80% decrease in the total surface area lost. It's been shown that contact stresses shift anteromedially with increasing size of a posterior malleolar fragment, and this results in clinically significant posterior instability. It has been shown that in posterior malleolar fragments smaller than 20%, the distal fibula and AITFL can effectively preserve your posterior stability. But there's concern that increased contact pressures and changes in where stresses are applied within the joint can lead to osteoarthritis. The primary concern is that the PITFL and transverse ligament attach to the posterior malleolus. So multiple studies have shown that fixation of the posterior malleolus via a prone approach can increase syndesmotic stability as compared to fixing lateral and medial malleoli in a trimalleolar fracture via a supine approach. In one study, up to a quarter of those fractures required subsequent posterior fixation to adequately stabilize the ankle. So it's generally agreed that any ankle fracture that has some degree of posterior involvement likely leads to worse functional outcomes, and that's probably due to its effect on the stability of the syndesmosis. In terms of mechanism of injury, most posterior malleolar fractures result from external rotation, although there are other patterns seen. But the bottom line is that most often these fractures are associated with higher energy and more complex rotational fractures. In terms of classification, there's the classic Volkmann or Earl fragment, which is an isolated posterior malleolus. These are pretty rare. They're probably due to a hyperflexion of the ankle with a vertical loading force. The Haraguchi classification is probably the most commonly used, which was the first CT-based classification. And essentially, it categorizes these into more posterolaterally based fragments versus those that extend into the medial malleolus. And then you have type 3s, which are just the kind of the small shell, sleeve fractures at the posterior lip. There's also a Bertonacek classification, which is a modification of that, and Mason and Malloy classification, which sort of categorizes these based more on ligamentous attachments, but the patterns are basically the same. So when you're initially managing these, you need to have a thorough understanding of the exact mechanism of injury. The integrity of the soft tissue envelope, of course, is very important, as this can dictate your potential surgical approaches. It's important to keep in mind that with larger fragments, reduction might be impossible to obtain. So in some cases, if soft tissues don't allow for immediate fixation, external fixation may be necessary. And very careful review of imaging is very important. You really want to look at the overall direction of tibiotalar subluxation. You want to look for a misty mountain sign, which you can see on the image on the left there, which indicates a posterior malleolar fracture. And then CT scans are very important. Any ankle fracture that is suspicious for a posterior injury should get a CT scan, and there you want to be looking at the size of the fragment, any extension into the medial malleolus or the incisura, the level of comminution, and then very importantly, any articular impaction or osteochondral fragments that are incarcerated in the fracture. And the CT should always be obtained post-reduction. So in terms of treating these, again, the size of the fragment has sort of been the traditional deciding factor. The numbers that have been thrown around in the past are, 20%, 25% of the total tibial plafond. More recently, there's been some studies that have talked about 10% or even 5%. But overall, the trend is focusing on restoration of the syndesmotic structure, not so much on the size of the fragment. So multiple studies have shown that fixation of the posterior malleolus improves reduction of the syndesmosis. And so fixation of the syndesmosis alone is not a substitute for fixing the posterior malleolus. Some other work has showed that restoring syndesmotic strength by fixing the posterior malleolus gives you 70% of the overall integrity of the syndesmosis versus 40% with just transsyndesmotic screws alone. Other studies have shown improved clinical and functional outcomes with repair of the posterior malleolus. And it's also been shown that malreduction of the posterior malleolus leads to malreduction of the syndesmosis in the coronal plane. Despite all this information, the decision of whether to fix a posterior malleolus is still nebulous. A survey in 2011 showed that 56% of orthopedic trauma surgeons base their decision on stability as opposed to size. But in terms of the size of the fragment, 100% of surgeons said that they would fix it if it was 50% or more, but only 9% said that they would fix a posterior malleolus if it was less than 10% of the plafond. Van Hoof showed that fixation of medium and large fragments improves long-term outcomes. And again, this is likely due to the fact that posterior malleolar fixation improves stability of the syndesmosis. So, the things that I look at are syndesmotic instability or talar subluxation when deciding whether or not to fix the posterior malleolus. So which approach to use? Traditionally, it was always anterior to posterior percutaneous screw fixation, especially for smaller fragments. Huber et al. Showed that you can get a much better reduction with a direct approach rather than indirect percutaneous fixation. The posterolateral approach is typically the preferred approach. It gives you direct access to that posterior fragment, allows you to look at the articular surface and look for any entrapped osteochondral fragments. It avoids the major neurovascular bundle, although the sural nerve is at risk. One of the best things for me about the posterolateral approach is you can fix the fibula through the same incision, and typically we do these prone, and the prone positioning, you can use gravity to help position the ankle, in a better alignment for your fixation. So this is an example of a trimalleolar fracture fixed through a posterolateral approach. The fibula was repaired through the same incision, and you can get a good visualization of the incisional component of the fracture through this approach. The posteromedial approach is also quite useful, more for fractures that extend into the posterior colliculus of the medial malleolus. And if you have any posteromedial articular impaction or comminution of the medial malleolus, this might be a better approach. The neurovascular bundle is at risk, but just need to be careful with that. There has been concern in the past, as the posteromedial incision is in the watershed zone in terms of wound healing complications, but studies have shown that the risk is actually quite low. And in any fracture where the PITFL is completely disrupted, the posteromedial approach is ideal, as you don't have the ligamentotaxis effect from the ligament that you get from a posterolateral approach. So here's a case that was done through a posteromedial approach. You can see there's more medial extension of the fracture, and there's some comminution of the medial malleolar component, and a posterior buttress plate can really cover the entire posterior malleolus fracture from the medial side. In terms of fixation strategies, you can obtain reduction indirectly using ligamentotaxis and or application of a clamp from anterior to posterior in percutaneous fashion, or you can do an open approach. The direct approach has been shown to give you a much better quality of reduction as compared to anterior to posterior screw fixation, and posteriorly based screws through an open approach or posterior buttress plating have been shown to produce very good results. So the question then becomes, are screws enough, or do we need to use plates? More recently, surgeons have become more comfortable with the posterior approaches, and there's an ever-growing availability of pre-contoured posterior and now even posterolateral and posteromedial plates. So there's been a growing interest in looking at plating versus screws-only fixation. And multiple studies have shown improved biomechanical characteristics with posterior buttress plating as opposed to screws, as well as improved outcomes as judged by foot and ankle scores, range of motion, and also radiographical parameters with reduced articular step-offs with buttress plating. So when I'm thinking about these, when I'm deciding when not to fix a posterior malleolus, the size of the fragment is probably less important than stability and accurate reduction. The things that I look at are any posteriorly directed subluxation of the talus, or even posterolateral is going to make me lean towards fixing the posterior malleolus. Any articular impaction or incarcerated fragments should steer you towards fixing these, and extension into the medial malleolus or into the incisura as well. And when considering how to fix it, We have posteromedial and posterolateral approaches, which are very useful, and buttress plating appears to produce better clinical and radiographic outcomes. So the posterior malleolus probably plays a much larger role in ankle stability than we previously thought. The indications, of using your 25% rule are probably outdated. Posteriorly based approaches give you a much better ability to get a good reduction. Buttress plates are probably advantageous biomechanically as compared to screws, and direct stable fixation of the posterior malleolus likely leads to better patient outcomes. I think that's all I got. Thank you.
Wonderful, thank you. So I'm actually up next. I'm going to be talking about the syndesmosis, getting it right. My name is Nicole Stevens. I'm one of the trauma surgeons at NYU Long Island. So we will just jump right in. A couple people have just wanted to make a note, made some Slido questions. If you guys ask on there, I'll collect them at the end, and then we can talk about them at the end during the questions and cases section. So here's what we're going to talk about. The anatomy of the syndesmosis is very important, and there are 4 key structures that you need to know about. The first is the anterior inferior tibiofibular ligament. The second is the interosseous membrane. The third is the posterior inferior tibiofibular ligament, which Dr. Patel already mentioned, and is really important because it constitutes 42% of the strength of the syndesmosis. And lastly, the transverse tibiofibular ligament. So these 4 structures make up the syndesmosis, and everybody's syndesmosis is a little bit different, which is why it's so hard to get right. If you look at these cross-sectional imaging strategies, you can see that this syndesmosis on the left is very flat. And so if you can imagine, if you are trying to reduce the syndesmosis with a clamp or with a lot of force, that fibula can shift very easily up and down that flat surface. Whereas if you look at the right picture, this is more of a crescent shape, and it kind of snuggles in there, and it's oftentimes a little bit easier to reduce. So when you're looking at evaluating the syndesmosis intraoperatively, once you've fixed the fibula and you're moving on to fixing the syndesmosis or determining whether or not you need to fix the syndesmosis, there are 2 different tests that you can do. So you can perform the cotton test, which is where you grab hold of the fibula with a clamp of some sort and direct a laterally applied force, and you look at the medial clear space and see if it widens. Or you can do a stress examination where you hold the foot in dorsiflexion and you externally rotate the leg. And the same thing, you're looking at this medial clear space to see if there's widening. If there's widening more than 5 millimeters, you probably need to fix the syndesmosis. But how do you go about doing that? There's 2 real different ways that you can fix the syndesmosis. And holding the reduction can sometimes be very challenging. So I found that it's best to manually reduce the syndesmosis, which means holding the foot in dorsiflexion, because the talus is wider anteriorly. So if the foot is plantar flexed, you can overcompress the syndesmosis, and internally rotating the ankle to reduce the medial clear space into a reduced position. They've shown that the manual reduction has a lower risk of overcompression or malreduction, but it's not always possible. So if you don't have a lot of assistance available, if you have a really severe and widely displaced syndesmosis, this might be challenging to hold it manually. And if it's not able to hold the syndesmosis manually, you might need a clamp. But clamping the syndesmosis, they've found, has had a high incidence of malreduction or malrotation. So you have to be really critical about where you place your clamp. So when you're placing the clamp, you're normally going to use some sort of periarticular clamp or a point of reduction clamp. And you want to make sure that you're directly over the lateral malleolar ridge on the fibula, and that you're just at the midpoint of the tibia, about 10 centimeters above the joint. They've shown that moving this clamp really in any different direction or having the tines not off the central axis can cause malreduction as you tighten the clamp. So you have to be really careful about that and be hyper cognizant as you utilize your clamp. And then when you're putting the clamp on, you don't want to have any significant force across the clamp. You should hold it enough that it's reducing it, but you don't need to, squeeze the heck out of it, because then you could malreduce your syndesmosis by over compressing it, which can lead to long-term disability. So how do we do at reducing the syndesmosis? So when you look across the board, studies have shown that we are pretty bad at it, actually. So we malreduce the syndesmosis about up to 50% of cases. And this can be in a number of different ways. So you can malreduce the syndesmosis by not attaining your length in your fibula. You can malrotate the fibula fracture or rotate the entire fibula within the syndesmosis, which can lead to abnormal contact pressures. You can have sagittal plane translation, which is a big issue when you're using the clamp to close down the fracture. The fibula, especially if it's a flat syndesmotic incisura surface, can rotate either anteriorly or posteriorly, or you can overcompress it. So how do you mitigate these factors, and what do you do to get it right? And the one piece of advice I have for you is to be really, really critical of your fluoros. And so we're going to spend some time going through and looking at a fluoro so that we can check all different components of the syndesmosis. So as we get started, the first thing that you want to look at is you want to look at your joint line. You want to have equidistant and parallel joint space across the entire tibial plafond. So starting at the medial malleolus, going across the tibial plafond and into the fibula, that space should be even across and symmetric. So if it's not symmetric, you need to do something about it. Secondly, you want to look at Shenton's line. So Shenton's line is on the lateral border of the talus, and it's a line drawn from the plafond around the corner of the fibula, and there's a little medial fibular spike which should point directly at the tibial subchondral bone. This helps to ensure that your length is correct, and if you have a broken Shenton's line, that might mean that your syndesmosis is malreduced or your fibula is too short. Kind of going along with this and assessing your fibular length, you want to look at the Dime sign. So the Dime sign is the distal tip of the fibula, along with the lateral process of the talus. And you want those two things to fall into a dime-sized circle that's drawn around that area. If your fibula is too short, you'll have a broken Dime sign, so you won't be able to reconstitute that circle. And then on the lateral view, you can look at the lateral fibular distance, and you can look at it anteriorly and posteriorly. They found that posteriorly is a little bit more effective, but you want to compare this to the contralateral side. So if you're not sure, if you have a really badly displaced syndesmosis, you're not sure what it's supposed to look like, never be afraid to get contralateral x-rays so that you can compare both sides and try to match it appropriately. So you're really looking at how much of the posterior malleolus is visible behind the posterior shadow border of the fibula, and you want that to match your contralateral side. And it's typically pretty specific to patients between both sides. You want to also look at the tibiofibular clear space, which should be less than 6 millimeters away. So if you have too much gapping there, if it's too wide, you should be careful of that. And then finally, your medial clear space, the number to remember is less than 4 to 5 millimeters. If it's wider than that, then your syndesmosis is malreduced. More recently, since we're pretty bad at reducing the syndesmosis in general, people have looked at using intraoperative CT, utilizing O-arms to try to check their syndesmotic reduction. This is pretty new, and it's interesting to see how many people are actually changing their fixation after they've spun something through the O-arm. But if we look at the picture on the left, you can see this syndesmosis is over-reduced. So if you look at the anterior aspect of the fibula, it's really crunched in, and there's sagittal imbalance and it's too tight here. So the surgeon here revised it. And then if you look at the second spin, you can see that this is a much more symmetric looking syndesmosis across the entire A to P distance. So they fixed it so that it's not overcompressed and translated. Once you decide, you've got your reduction good, you're ready to go, how do you fix the syndesmosis? So there are a couple different strategies. So first, you want to fix it 2 to 4 centimeters above the mortise. You want your fixation to be parallel on the mortise view, and then you typically have to drop your hand about 15 degrees because the fibula tends to sit a little bit posterior. You can either use screws or you can use tightrope technology to fix the syndesmosis. Screws are very controversial. People talk about how many screws you need that's sufficient, how many number of cortices you need, whether it should be 3 or 4, whether or not you should routinely remove screws. And this has been debated for a very long period of time, and I don't think there's any real clear consensus. But more recently, the tightrope has come into play, and you put it in the same place where you'd put your screw fixation. And when compared to screws, they have found that there's lower incidence of malreduction, which is quite significant, 15 to 39%. There's significantly higher functional scores starting at 3 months, and they have lower complication rates, and you don't have to worry about hardware removal. So there seems to be a shift going with increased tightrope fixation. So in conclusion, restoration of syndesmotic anatomy is critical in the treatment of ankle fractures, but it can be very challenging. And the way that you should combat this is by being hypercritical of your reduction intraoperatively. And when in doubt, you should compare it to the contralateral side. And newer evidence is suggesting that tightrope fixation has been shown to have better functional scores and lower complications when compared to screw fixation, but it is still relatively controversial. Thank you so much. And next, we are going to move on to Dr. Nirmal Tajwani, who's going to be talking about early weight bearing. Is it time?
Good evening. Definitely time for my talk. Thank you, Nikki. Okay, we heard about syndesmosis. We heard about posterior malleolus. Now we're going to talk about weight bearing after ankle fractures. Now, weight bearing after ankle fractures is kind of sort of controversial, and a lot of people don't want people to weight bear. And I think I like this editorial that was published a couple of years ago by Alex Trumpeter from England. And essentially, he's asking the question, why do we not let people weight bear? What are we afraid of? Are we afraid of failure? Are we afraid of non-union? Are we afraid of implant failing? And the question is, what is the reason? And let me try to go through the rationale or logic of what the problem is with non-weight bearing. So let's start off with bone and muscle mass. Well, we know that in less than 2 weeks, you're going to start losing bone and muscle mass. And this applies to everyone. 10 to 15% loss of muscular strength per week, and almost 50% in 3 to 5 weeks of immobilization, and then recovers a very, very slow rate of only 6% per week. So you can see you lose mass over 2 or 3 or 4 weeks when it takes you months to recover that mass back. Similarly, biomechanics. I mean, you do need bone to have stress applied to it for it to mold or change or heal. And same thing with parent strain theory. You need some sort of motion. Now, increased bone mineral density happens with weight bearing. And I think this is very important as we all get older. In a younger patient, probably not big a deal, but an older patient, I think it's definitely an important issue. Similarly, the stimulation of bone through weight bearing is actually leads to earlier and higher quality callus formation. And we kind of see that with nails, right? When we do intramedullary nails, we let people walk on them, and they all seem to throw a lot of callus and heal pretty well. How about stuff that's not orthopedics? Well, there are significant cardiovascular effects associated with prolonged immobilization. And we know that, again, in the elderly, this is a big problem. And this is why we want people to get up and walk after hip fractures, for example, because otherwise we would result in them getting pretty sick from pulmonary complications, vascular complications, and then, of course, death. So how about weight bearing after fractures in general? What is this based on? It should be based on patient and fracture factors. Unfortunately, it's also based on surgeon's preference / bias, and maybe some research, right? So what are the patient factors? Well, whether the fracture is articular, how much comminution there is, whether it's upper or lower extremity, and what are the functional demands or needs of the patient who has a fracture, and therefore what needs to be done, right? And this is big, surgeon's preference, right? Most of us have protocols based not necessarily on science, but a lot on our training. And of course, as we say, we are only as good as the last complication, which essentially feeds into our biases of how we want to treat patients. And literature that we all are familiar with when we train, so somewhat older literature. How about partial weight bearing? You can say, well, listen, you can let them weight bear somewhat, so they're not truly non-weight bearing. And I think partial weight bearing is kind of a myth. I suspect it makes us feel better that we're letting the patient not walk with all their weight. But a couple of studies that have been done over the years have shown that a younger patient is actually not able to do what partial weight bearing is. And these are normal people in the lab. So they know they're being watched, they know they're being, tested, and yet they couldn't do it. And obviously it's worse in the elderly. So expecting people to be compliant with non-weight bearing, especially when it doesn't hurt, is going to be very, very hard. So how about returning back to foot and ankle? What do we think? So this is a meta-analysis of multiple reviews, 10 randomized controlled trials, which basically went on to show that there was significantly better short-term post-op scores, significant reduction in time to work and daily activities, and there was no difference with immobilization versus range of motion. So range of motion was not that big a deal, but weight bearing definitely was. Similarly, there was no change in complication rate, and by 6 months, the outcomes are about similar. So let's go with some examples of cases and what I would have done. So here's somebody who's 93, so older lady who was getting into a bus, so independent enough to be outside, and she has this ankle fracture. And you can argue, what are we going to do now? She's 93. At this age, you keep her non-weight bearing, it's a problem. So this is her CT scan. She's got a small posterior malleolus. And Milan, I didn't listen to you. I didn't fix the posterior mal. I fixed the lateral and the medial side. And we actually put her in a boot and let her start walking because we thought at 93, we couldn't really keep a non-weight bearing. And she actually did remarkably well, was back to walking. She had very little pain after the first couple of days, and she was back to her baseline by 3 months, which I think if we had kept a non-weight bearing, I don't think would ever happen. Another example, which is younger patient, higher energy trauma, has an ankle fracture dislocation. Here we can see a mostermal piece, and we actually did go from the posterior side, fix the lateral and the posterior malleolus. And this one, we put him into a splint, and then at 2 weeks, we put him into a boot, let him start walking. And same thing, by 6 months, he was running and doing pretty well. So pretty good outcome there. Here's something that we did at our institution, and most of us on this call participate on this. And we randomized patients to early weight bearing, which is 2 weeks, and standard non-weight bearing for 6 weeks. And we included trimalleolar fractures. Our exclusion was syndesmotic fixation. And we presented this at our annual meeting recently, and we had no failures or difference in soft tissue complications. The functional outcomes and return to work was significantly faster in people who were weight bearing, as you would expect. And in an urban environment like New York, where people need to get up and walk and take public transport, I think this is a big difference. They definitely also had better pain scores, which is interesting, at 6 and 12 weeks when they start walking earlier. And I'm going to close up with one last case, which is slightly different. And you can see it's more of a distal tibia with articular extension. So it's almost a ankle as well as a tibia fracture, lower energy. And this one, we put a nail down, fixed the ankle with screws, and we let them walk right away. And same thing, patient went on to do much better than we would have expected without being weight bearing. So what's my conclusion? I think I allow weight bearing for all comers. The exceptions in my hands are syndesmotic fixation and diabetics and those with neurological compromise, where we are concerned about them developing a Charcot joint. And I think the tide is turning. This is true not only for ankle fractures, but also for other body parts, or distal femurs, in some cases proximal tibias, and to allow people to have unrestricted weight bearing to facilitate the rehabilitation until the evidence suggests otherwise. Thank you.
Excellent. Thanks so much, Dr. Tejwani. Next, we have Dr. Sunny Kanda telling us about percutaneous ankle fixation, when, why, and how.
Thanks, Nikki. So I'll start off and preface this talk by saying, percutaneous ankle fracture fixation is really a tool that the orthopedic surgeon can use in their toolbox. By no means do I suggest that this is the primary means of fixation. But in this talk, what we're going to do is we're going to talk about the indications for percutaneous ankle fracture fixation. That's the when and the why. And then we'll go over some case examples to illustrate the when and the how. Okay, so when we talk about indications, one great indication to do percutaneous ankle fracture fixation is certainly when you have bad soft tissue injury around the ankle. Here's an example of an open tongue-type calcaneus fracture, circumferential traumatic laceration around the ankle. And if you look closely at that lateral x-ray, the talus is actually subluxed. Once the patient was taken to the OR, underwent temporizing fixation with some Steinman pins from the calcaneus into the tibia, you can see the patient had a displaced medial malleolus fracture. This would be a great indication to try to do something percutaneous because you don't want to traumatize the tissues anymore. Another indication, patients with poor wound healing. Here's an actual patient of ours. This is actually Dr. Ganta's patient, hemoglobin A1C of 17.5. Someone who you don't want to operate on. This is someone who Dr. Ganta has great experience as our diabetic ankle fracture expert. And sometimes you have lacerations of arteries around the ankle. When you have lacerations of artery around the ankle, you're going to have compromise of the angiosome. When you have compromise of the angiosome, we've shown and published that making lacerations in those areas will certainly lead to poor wound healing. And then patients have some medical comorbidities that are going to make them prone to poor wound healing, peripheral vascular disease in particular. This is an example of two ankles of what it will look like when you have this patient present to you. Now, very elderly patients. Certainly, we can do open reduction internal fixation, and we do in the vast majority of elderly patients. But when you have a very low demand patient who still does need to get up and walk, maybe they're just doing transfers, they need to do some routine hygiene. This may be a patient where really achieving a stable ankle mortise is the goal, and just getting them up and walking, as Dr. Tejwani had alluded to, with regards to early weight bearing. Certainly, when you do this percutaneously, you can still achieve that early weight bearing. Axially stable fibula fractures are a great indication in my mind for percutaneous fixation. These just need to get the fibula lined up, and then once you do that, you can put a screw or a wire fixation, and you don't have to worry about a length stable construct anymore. Non-displaced medial malleolus fractures are a good indication for percutaneous ankle fracture fixation. I will point out that it's rare to have a truly non-displaced medial malleolus ankle fracture. You need to take care to ensure that there's no periosteum or anything flipped into the fracture site that may inhibit healing. But when you do find these, sometimes these will be good indications to do that. Posterior malleolus fractures without articular comminution, another great indication for percutaneous ankle fracture fixation. So let's get into some case examples. So here's an example of a comminuted distal tibia shaft fracture. And has an associated comminuted bimalleolar ankle fracture. The fibula is comminuted. The posterior malleolus is a minimally displaced fracture. And this would be a great indication to fix the ankle component of this percutaneous because there's a large soft tissue injury just above it. And this is what was done. This is an intramedullary nailing. It's have 3 distal locking bolts, but the posterior malleolus has been fixed with 2 anterior to posterior percutaneously placed screws. And the fibula fracture has been fixed with just a guide wire that's been placed in a percutaneous fashion. Here's an example of a 57-year-old female. She has a minimally displaced bimalleolar ankle fracture. When you see a fibula fracture like this, even on the AP and the lateral view, there's no clear fracture line. This is oftentimes more of a crush type injury. The periosteum around the fibula is usually intact. This is a great indication in my mind to put a percutaneous screw in. Voids the dissection around the periosteum. The fibula will heal routinely without any issues. As you can see here, though, as we did a stress examination before we did anything just to see how stable the ankle fracture was. It is an unstable ankle fracture. The medial malleolus is opening up significantly. So we decided to percutaneously fix the fibula. This is fixed with a 4.5 millimeter cortical screw. The incision is placed 1 centimeter distal to the fibula. The medial malleolus was fixed through an open reduction because of the amount of displacement that was there. It's always important after this is done to stress the ankle joint. And certainly when you do fix the fibula percutaneously with screws, you can put screws around, or even the suture button fixation device that Nikki alluded to, you can put those around the screw, but you do need to assess to make sure that the ankle syndesmosis is still intact. And this is a patient 6 months postoperatively. The fibula is healed without any issues. The ankle mortise remains congruent and stable, and we've avoided any major incisions around the lateral aspect of the ankle. And here's an example of an 85-year-old gentleman. He just missed one step as he was walking down the stairs. He has a minimally displaced bimalleolar ankle fracture. Certainly, as you may hear, Dr. Eagle is going to talk about patients who can be treated potentially without surgery. This is certainly someone who could potentially be placed into a cast. I think they would have a good outcome. This is also someone who we had a discussion about putting into a cast, but certainly wanted to avoid a cast. He wanted to try and start walking on this immediately. And so percutaneous ankle fracture fixation for something that is truly not an ankle fracture dislocation, where there's good periosteal sleeves around the medial malleolus and around the fibula, would certainly be amenable to fracture fixation. One of the things to take into consideration here is this gentleman is a little bit older. He has more osteoporosis in the fibula. The canal is a little bit more capacious. So to fill the canal, here we've used a 6.5 millimeter cannulated screw. Take caution when using the 6.5 screw. You have to really be sure that the screw can fit up the proximal canal, or you have a risk of comminuting the canal. But one of the benefits of this technique of using a cannulated screw is the wire can be advanced into the proximal segment, and then the screw can just be placed directly over it. The medial malleolus here has also been fixed percutaneously. This is a great example of where the medial malleolus was not displaced, and then it can be fixed through just 2 screws placed in a bicortical fashion. Again, because the patient is osteoporotic, we wanted to get better fixation. Again, the ankle is stressed and syndesmosis is stable. This is another example of a comminuted trimalleolar ankle fracture. The ankle is subluxed, the medial malleolus is comminuted. And in this scenario, we did a percutaneous bridge plate on the lateral fibula, and a minimally invasive open reduction of the medial malleolus was performed. The care was taken not to disrupt the periosteum around the medial malleolus, and this was fixed with 3 screws. This would have been amenable potentially to even a mini fragment type plate. When you're doing the bridge plating, this is what it'll look like. This is not the same patient, but this is an example of what a bridge plate will look like. It can be done through small percutaneous incisions where the fibula plate is slid submuscularly under the perineal muscles along the lateral aspect of the fibula. I probably would not recommend doing this with a plate greater than 7 or 8 holes. At that point, you have to start contouring the plate. It'll be very hard to fix the plate anatomically to the fibula. Here's a comminuted partial articular pilon fracture with an associated transverse fibula fracture. You can see on the lateral view here, the talus is extruded anteriorly, so fracture dislocation. The patient's been splinted, and here's a CT scan demonstrating the comminuted nature of the fracture. In stage 1, the patient was placed into external fixator. A good reduction was achieved after waiting the appropriate amount of time for soft tissue swelling to resolve. The patient was taken back for a formal open reduction internal fixation. So the articular portion of this was fixed through an anterolateral approach. A smaller separate medial incision was made to fix the medial malleolus. With already 2 incisions around the ankle, the decision was made to fix the fibula through a percutaneous approach. And here, this is an axially stable fracture. So a small incision can be made directly over the fracture site. Care has got to be taken to dissect down to the fracture site and protect the superficial perineal nerve. But you can put lion jaws around it or whatever type of clamps you'd like to around the fibula and then distract it and kind of get it reduced, especially because it's axially stable. At that point, then you can then insert, in this case, I believe was a flexible nail, was inserted across the fracture site. And again, this was done through a small incision. And here's an example of a trimalleolar ankle fracture. Again, minimally displaced, so the fracture, this ankle was never dislocated. It's a good periosteal sleeve around all 3 fracture components. Minimal fixation was performed. Here's a 4.5 millimeter cortical screw for the lateral malleolus and just 1 screw for the medial malleolus. And this is the last case I'll end with, but you can still, once you're done fixing these, you can still put these patients into a cast. You can protect your repair and still get them weight bearing in the cast. And so you can do walking casts, and this patient was placed into a short leg well padded cast and given a cast shoe to walk on and did well. So in summary, percutaneous ankle fracture fixation is a good tool in the orthopedic toolbox. The indications, however, are limited. Typically, it's patients with soft tissue compromise, poor wound healing potential, and then elderly patients with amenable fracture patterns. These are all done with fluoroscopic guidance. And stable fixation in a congruent ankle mortise can be achieved with this technique. Thank you.
Thank you so much, Dr. Khanna. Next up, we have Dr. Ken Eagle talking about human beings can heal in a cast.
Okay, well, thanks very much, Nikki, and thanks to my colleagues, and thanks to everyone who's joining us tonight. So, this was really about non-operative care of ankle fractures and who are the patients who can benefit from it. Now, we all like to fix ankle fractures. Oh, I don't have control. There we go. We all like to fix ankle fractures, but we all want to avoid what we see here. Exposed hardware, fracture non-union with late mortise widening, acute wound breakdown with exposed hardware, and gross purulence. And nothing is ever so bad that we can't make it worse. So a little bit of insight from me, because I've reached old guy status. And this is something I thought about. And we spend 5 years of residency learning who to operate on. And then we spend the rest of our careers learning who not to operate on. And as I do more and more of this, and I see more things and I see more problems, I find this to be more true than not. So I've learned a lot about who I shouldn't operate on. And I think that's something that we don't do a great job of teaching our residents. And here's just an example. This is a patient who I saw a while ago, many years ago, in the emergency room. He came in for something else, and the ER had gotten an x-ray of his ankle because he had complained about something related, but not really his ankle. And he'd had this ankle fracture about 20 years prior. And this is what he's been walking around on, but he had been doing fine for 20 years. And this is a pretty bad-looking ankle mortise. But, he went on to function quite well. So, we always try to do the best we can for patients, and we think what we're doing is always going to change their natural history. And we have to remember that we have to treat the patient, not the x-ray. So this is a little bit of a different story, and this is probably one of the most common areas that we see, and there's a lot of debate about, and it's gone back and forth, and the pendulum swung one way and then the other, and now back the other way. And frankly, I'll have to admit, I've been at the some of the forefront of this, and maybe this has led to operating on too many ankle fractures. But this is the isolated lateral malleolus, and we generally recommend in young active people that we want to assess ankle mortise stability, and these patients will stress them, and if their medial clear space opens more than 5 millimeters, or we see syndesmotic widening, we find that to be an indication for fixation. And that's probably something that most of us still follow, especially in young people, active people. But as we get more towards the middle age and older patient population, for a lot of the reasons that have been discussed, maybe it's not the best thing. And this was a paper, courtesy of Dave Sanders and the Canadian Orthopedic Trauma Group, that they published over 10 years ago. And this is the kind of study that you can do in Canada. Basically, they took people who had an unstable ankle mortise, isolated fibular fracture. They stressed them and they opened more than 5 millimeters, and then they randomized them to operative fixation versus cast fixation. They had about 80 patients, 40 in each group, and the results were somewhat promising, but they did have about 20% of people who had late mortise widening. So again, you can treat people in a cast, but they may go on to heal with a fibular malunion that leads to medial clear space widening. And we know an incongruous mortise is going to probably develop arthritis at some point. Now, the main critique of this paper, obviously, is that it only had 1 year follow-up. And even a poorly fixed lateral malleolus or a poorly reduced ankle mortise probably won't, manifest symptoms for much longer than that. So the real question is, do we need to stress these? This is the teaching, and it's something that I do in my practice, and I teach the residents to do. But Ken Koval showed us that in certain cases, in patients who, might fall into the categories of either not wanting surgery or not being good surgical candidates. You can get an MRI, and when he did this in 20 patients with stress positive ankles, he found that there was some ligamentous stability that remained by MRI. So with this, he treated these people non-operatively, and they did reasonably well. Again, no long-term follow-up, but the key is, what does the ankle mortise look like at the time of healing? If it heals with a congruous stable mortise, the patient's going to do fine. If they heal with a non-congruous mortise, they may do fine and they may not. So just some cases to give you an idea. Here's a 70-year-old lady. She was a normal functioning lady, but had recently developed encephalitis and was recovering from this in a TBI unit, slipped and fell and had this ankle fracture, which we agree the talus is shifted and there's medial clear space widening, or talus is tilted. It's an unstable ankle mortise, but given the fact that she'd been through all this recently and still wasn't ambulating, she was reduced and treated in a cast. And saw her at 5 months. Her ankle mortise was healed. She was stable. She had begun walking about a month before, but for the most part was still in her wheelchair. So, I thought this was a good patient and a good opportunity to manage her non-operatively, and I think the family was happy that we did. They weren't really interested in any surgery at the time. And it's not just the isolated fibula fracture. We can treat bimalleolar ankle fractures, trimalleolar ankle fractures non-operatively well. Here's an 80-year-old patient, again, lower demand, close reduced, treated in a cast. If you want, make them weight bearing as tolerated. If you think a patient is a poor candidate, they're elderly, you're worried about them weight bearing, you can reduce them and hold them in a cast and allow them to weight bear. All you have to do is make a foot plate on the cast. Now, this is something that is an art that is lost. I think most orthopedic surgeons today and the residents today aren't trained to place casts properly. At our own place, they have some places where a cast tech puts on all the casts, and the residents get no real experience in learning how to place an appropriate cast. But placing an appropriate cast can be a very, very valuable skill as we talk about our toolbox and armamentarium. Now, patient selection. Again, we were talking about elderly patients and getting them weight bearing. A lot goes into determining, who you're going to operate on. What's their level of independence? What's the vascular condition of the limb? I would argue that if you were to do some invasive and non-invasive vascular testing of the limb, you would find significant vascular disease in the majority of patients over age 70. Okay. So again, it's about having a conversation with the patient and the family and find out what they expect. So here's another case. This is an 89-year-old home ambulator only and minimal at best. Pretty bad ankle fracture dislocation. She gets reduced in a cast. And, reasonable reduction. Is it going to hold? Who knows? She kind of disappears and comes back. And this is where she is at 1 year. I saw her recently. No pain. She still walks around her apartment and gets to and from the bathroom and has no complaints with regard to the ankle. The ankle is stable. I was manually trying to see if it's subluxed or not, but it didn't. Her fibula went on to heal. X-rays don't look pretty. The patient and her daughter were very, very happy that we avoided surgery, and she got back to the existence that she had before this injury. So in summary, most unstable ankle fractures are best treated with surgical stabilization. Certainly in young patients, active patients, middle-aged patients, we can all agree. A stable ankle mortise does lead to the most reliable outcomes. Are we potentially operating on too many? Maybe. I see what's going on now with people fixing humeral shaft fractures and fixing non-operative LC1 pelvic ring fractures. And maybe that's the way people thought when we started fixing a lot of these ankle fractures 25 years ago. Are there people who should not be operated on? Yes, I think we all agree with that. And in summary, I will just tell you that human beings, since the time of the caveman, with ankle fractures can be treated non-operatively without surgery. And some may do well. Thanks very much.
Thank you so much for that talk. And rounding us out for the end is Dr. Abhishek Gansa, who will be talking about immediate fusion indications for a TTC now.
All right, guys. Well, thank you for having me. And what I'm going to do is just go over some of the newer technologies that's been out there and some of the indications for a TTC nail. So the real disclosure is that this is not done commonly. I don't think this should really be the first line of treatment or the first line of fixation for a majority of ankle fractures. But I think what we can go over are just some of the patient-specific and injury-specific risk factors that you might think about that could potentially lean you towards using this as a modality for treatment for ankle fractures, okay? So the majority of the people you're going to be using this for is going to be for geriatric ankle fractures, all right? So there's a couple of patient risk factors that we think about when we see this cohort of patient population. So thin skin, poor soft tissue envelope, like Dr. Eagle pointed out, these are patients that can have very fibrous skin that can lead to wound complications. Patients with diabetes, whether it's controlled or well controlled. So, someone with long-standing diabetes for 30, 40 years, even if they're well controlled, still have some degree of neuropathy that's occurred over having disease for that long time period. Patients who are sarcopenic have very little muscle mass, and peripheral vascular disease can be pretty common in this patient population. So a lot of these patients are frail. They can't comply with weight-bearing restrictions post-operatively. Another thing that can be a challenge is cognitive impairment, right? So these are patients who are unable to comply with restrictions just from a mental standpoint and can't really communicate if they're having pain or having issues. So the injury characteristics you'll see in this cohort of patients is osteoporotic bone. And oftentimes these fracture patterns will be a lot more complex. You'll see a lot more marginal impaction. You'll see involvement of all three malleoli and sometimes even anterolateral impaction. So they can present as like peel-on variants and from just a low energy fall. So we go over treatment options and we kind of went over a couple of these before. So there's close treatment with casting, percutaneous fixation, which Dr. Konda mentioned, traditional open reduction, internal fixation. And what I'll go over is tibial-talar calcaneal fusion. All right. So I'm just go over some of the pros and cons of this. So, close treatment with casting can be successful. You're going to have malunion and non-union rates, and it's going to be highs up to 75%. Now, whether or not this is clinically relevant is something that is still in debate and is still kind of being parsed down in literature. The challenges with casting is there's an art to casting, and it can be challenging, especially in this cohort. You can get cutaneous complications. So there's a patient on the right. This patient was 90 years old, demented, had an unstable ankle fracture, was placed in a splint, came back, bone sticking through the skin, was unable to comply or, communicate with the family about what was going on. And she ended up getting a BKA. So, casting requires a lot of patient counseling and family counseling, and is not as, and can be a little bit challenging to do. Let's go over, percutaneous fixation. So IM fixation, whether or not it's with a screw or it can be done with fabricated fibrillar nails, is a good option. Ultimately, you're going to have malunions and imperfect reductions, right? Because if you're not making any direct approach and clamping the fracture, you're going to have some degree of malreduction. But, overall, the goal is to have a stable ankle mortise, which can be done this way. And you may need to supplement with casting on top of this and to make sure that your reduction is going to hold. Now, traditional open reduction and internal fixation in geriatric patients, you can have complication rates up to 22%. And these include infections, malunions, skin necrosis. And as the patients get older, above the age of 60, you're going to have increasing complication rates that can exponentially go higher. And so you have to realize that even with ankle fractures, which may not necessarily be like as severe as a hip fracture, right? There's still a pretty significant mortality rate, especially in patients in the age 60, and that can be even higher in patients above the age 40, above age 80. So we talk about TTC fusion nails. So what are the possible benefits for this, right? What does it provide that the other treatment modalities don't? So you can have immediate weight bearing, but Dr. Tejwani touched on this before, but these patients can be made weight bearer right away. And you're making incisions outside of the zone of injury. So you're basically trying to mitigate the risk of having wound complications right at where the malleoli are. And so if wounds break down in this area, your coverage options can be pretty limited. And this is going to be something a little bit more controversial, but you don't necessarily have to prepare the subtalar and the tibio-talar joint. And that's something that I think is patient and injury specific. And I think that's something that's still really not quite understood fully. And I think that's something that's going to be kind of shown over time as this treatment modality becomes more frequent and more randomized controlled trials are going to be done in the future with regards to this, with regards to TTC fusion nails for ankle fractures. So I'm just going to go over a case. This is a 60-year-old female. She's got Parkinson's, and she essentially ambulates just around the block in her neighborhood, so she doesn't go too far. So standard trimal fracture dislocation, common to the fibula. The patient's placed in a splint, and the post-reduction X-rays look really good. Now, if you look at the two cuts on a CT scan, you can see that the posterior mal looks like a large fragment, but you can see there's a significant amount of articular impaction that's happened. There's a medial malleolus fracture, and if you look anterolaterally, there's anterolateral impaction too, which can be sometimes a little bit difficult to treat as the fracture fragments are relatively small. And this could be one of the reasons why they may have syndesmotic instability after you have everything fixed, including the posterior mal. Lo and behold, you get in the operating room, you take the splint off, and this is what her skin looks like. So there's near full thickness skin necrosis along the medial side of the ankle. It's not an open fracture, but the skin there looks pretty terrible. And if you look laterally, there's fracture blisters everywhere. And you can see just our overall foot hygiene is not that great. So what do we do next? So, this is something that I discuss with almost every single patient, especially when they have this severe of an injury, the possibility of having an external fixation placed in the interim. And I did not potentially go into this case thinking that I was going to have to do a fusion nail, because when the ankle was reduced, while she did have some skin changes immediately, there was no significant amount of fracture blisters that occurred. So what I ended up doing is placing a stymon pin up the tibia just to kind of hold everything in place and placing an external fixation fixator. And, the challenging part in this patient population is that the X-fix can become soupy pretty quickly. The calc pins can loosen within 2 to 3 weeks, including the tibial pins as well. And so, placing the stymon pin up kind of holds everything in place and kind of neutralizes a lot of the forces that are happening along the external fixation. So we can go back to the 4 treatment options that we discussed before. What can we do? Close treatment with casting, obviously that's out of the question here. Percutaneous fixations can still be done, but I still get worried about the amount of fractional blisters that she had. And I'm not sure if that necessarily was an option, may not be the best option for her. Traditional open reduction internal fixation, still a viable option, but in this scenario, I think that her blisters would take a significant amount of time to heal. And you're looking at doing a delayed internal fixation, probably around, 3 weeks, 4 weeks, and sometimes even longer, if the blisters haven't epithelialized in time. And then, what we opted to do for this patient was a tibio-talar calcaneal fusion. Before we get into the case a little bit, I do want to review some of the literature that's out there. This is probably the largest study and the highest quality study that's available. And this is kind of one of the pilot studies, I guess, that kind of made this a popular treatment modality. So this is a trial in patients 70 years or older that were treated with a tibio-talar calcaneal nail instead of OIF. So the one thing they did exclude is cognitive impairment, peripheral vascular disease, and peripheral nerve changes with diabetes. And I think sometimes these 3 cohorts of patients would really benefit from this type of modality. But you can see that there's a low complication profile. I think it was almost 3 to 4 times lower in this study for patients treated with a TTC fusion nail compared to its traditional ORIF. And keep in mind that these patients did not get any joint preparation. So they had a nail percutaneously placed, they're made weight bearing as tolerated, and they had standard follow-up at that point. And the nail was removed in some patients if they requested. Another group study, and these are all going to be limited case series after this one study. 22 patients, unclear why they got the fusion nail and why it was chosen. Okay. So there is some inherent selection bias, but all patients were made weight bearing as tolerant post-operatively, but there is a relatively high complication rate. 13% patients had infection, some of the screws loosened and backed out. Some patients got DVT-PE. Whether or not that's something that's related to the implant is probably not likely. It's more of a patient selection issue, but they did show the 72% healing rate. Now, whether or not these patients required for multiple surgeries in the future for their malunions, I don't think so. I think most patients were relatively close to baseline thereafter. And then, fragility fractures in this series of 48 patients, everyone greater than 80, unable to walk independently. So these are pretty low demand, frail patients. And, they did include open fractures, which, could be a little bit challenging to treat in this patient cohort. And you do get worried about putting a TTC fusion nail in open fractures at, at times, especially if they have a very poor soft tissue envelope, because essentially if that gets infected, the entire tibia is infected, right? So, there was still a significant amount, not a significant amount, but a decent amount of complications. So patients with infections, broken interlock screws, valgus malleus, but overall, most patients went back to their close to their baseline level of ambulation. So this is a patient that, was brought back to the office very closely. And then she developed an unstable eschar over that medial side about 6 weeks post-operatively. I took her back to the operating room, debrided it, and basically probed down the bone. I took cultures, even though her inflammatory markers were negative. And you can see on the lateral side at 6 weeks, her skin still didn't look very good. And so give her a pin side holiday, put a wound back on. And the next steps were basically I have to get that medial side closed. So did a transverse incision over the medial side, did a shortening to allow the skin to close, and did an antibiotic intramedullary TTC nail. So you can see here, made a lateral incision, took out the fibula, was able to prep the joint, took out a medial malleolus, got what I thought was a reasonable alignment, get the joint ends close together, and shortened her enough so it can get that medial side to eventually close, and put a TTC fusion nail up with antibiotic-coated cement. She didn't really get antibiotics afterwards. And then 6 months post-operatively, this is what she ended up getting. I put her in a cast just to kind of minimize the amount of soft tissue trauma that she had in the area, try to get her wounds to heal a little bit better, and windowed the medial side to make sure it healed. But 6 months post-op, she was very minimal ambulator prior. She was back to her baseline, and she had a stable ankle mortise to walk on. So in summary, I think the TTC fusion nail is a good option, but it's ideal in a low-demand patient. I think the first randomized control trial did show that there's a very low complication rate, but nonetheless, especially in someone who has severe peripheral vascular disease or diabetes and they have neuropathy, I think those are the patients in which joint preparation might actually be somewhat beneficial, because these are people who can't really feel, any pain, and these are ones that end up getting screwed back out in the future. So I think it's important to have a discussion with the family regarding, possible reoperation, complications, and that it's kind of a goal-oriented surgery. We're just trying to get a stable ankle mortise for the patient to walk on, but it's not going to really make them revert back to what they were, at their pre-injury status. All right, I'll do the question and answer later, but thank you.
Thank you so much, Dr. Ganta. So with that concludes our lecture series. We had a number of questions come up in the chat, so I'm just going to throw them out to some of the presenters as we go. So the first question is for Dr. Patel. The question was, how would you approach the challenge in a posterior approach, fixing the posterior malleolus fracture, the fibula fracture, and then potentially if there's need for syndesmotic fixation? What order do you do things in? How do you what's your surgical plan?
Okay. It's a very good question. So I would say, first off, I would look at the the preoperative imaging, the injury films. If there's any posterior or posterolateral subluxation or dislocation, that's going to basically inspire me to go in the back and fix the posterior malleolus. A lot of times, you have a posterior malleolar fracture that's not very displaced, and if the ankle was not posteriorly subluxed, it just means that the talus rotated and broke the posterior malleolus, but the stability hasn't been compromised. But if you think it has, go in the back first, fix the posterior malleolus. Usually I do the posterior malleolus first. Sometimes I'll fix the lateral malleolus, at least with some lag screws, depending on the fracture configuration, just to kind of reestablish length on the lateral side, and then fix the posterior malleolus. And then, you can do your stress test or your cotton test. And if at that point you still have instability, then you can always add syndesmotic fixation, just, with screws or screws with washers or a little plate or something like that.
Thanks very much. Any other panelists have any comments on that? Okay, cool. Let's move on to the next question. This one is for Dr. Tejwani. With regards to weight bearing, when you say, start walking at 2 weeks, do you let them be partial weight bearing? Weight bearing is tolerated. Do you make them wear the boot? What's your progression?
So I give them a boot and tell them they can be weight bearing as tolerated, and they're allowed to put as much weight as they like. They can take the boot off to do everything they want to do, range of motion. But I tell them for at least the first 2 or 3 weeks, they should weight bear with the boot. And typically by 6 weeks post-op, I'd want them to get off the boot and start walking with shoes, regular shoe wear.
Absolutely. Thanks so much. This next one's a little bit of a curveball. I'm going to ask it to Dr. Eagle. How long after an X-Fix will you do ORIF? Is there a certain time limit that you wait for, or are there certain factors that you're looking for in the leg?
Sorry. We know that if we wait more than 2 weeks, you're going to start having to take down an early healing fracture. So generally, I try to get there within 2 weeks. And it's really based on the soft tissue. If the soft tissue doesn't allow, it's basically keep checking them pretty frequently and try and get in there as soon as possible. But if it's more than 2 weeks, you're going to have a lot more work on your hands and trying to take down some callus that's already formed. And always be aware of the pin sites, whether or not they're soupy, if they're close to where you're going to be operating.
When you're looking at a leg getting ready, it's in an X-Fix, what are you looking at? What are you looking for to say that it's ready?
That's a good question. There are a number of things that we look at. Obviously, we look at the amount of swelling. How do you determine that? I'm not sure. We look at wrinkles, compare it to the opposite side, look at compressibility. If they've had blisters, have the blisters been unroofed? Is the area reepithelialized? Generally, rotational ankle fractures will generally be ready within, 7 to 10 days, 2 weeks max. It's a different injury than a pilon. The amount of energy is much different. So on rare occasion, it's going to be longer than that and be more significant. I've never actually seen an isolated lateral mal that was ever too swollen to operate on. I think you can operate on those immediately. I'm never really worried about that if it's just one side.
Thanks very much. There was an interesting question actually about DVT prophylaxis. So I think I'll actually just pull the group. For your ankle fractures, are you giving them DVT prophylaxis? And does it matter if you're keeping them weight bearing or non-weight bearing for 6 weeks? So I'll start with Dr. Ganta.
So for DVT prophylaxis, I think it depends on the patient. So someone who's morbidly obese, smoker, for those type of patients or someone's going to be immobilized for a while, I'll probably put them on something a little bit stronger than aspirin. But the average patient who's healthy and has a regular BMI, I'll put on aspirin twice a day.
Dr. Kanda?
I do aspirin twice a day for 4 weeks as my baseline. And just like Dr. Ganta, someone who's considered high risk for DVT, potentially either Lovenox or Eliquis.
Dr. Eagle?
Yeah, I used to use Lovenox for everybody, regardless. That was more for medical legal. Now I've gone to aspirin BID as well, secondary to the Prevent Clot study. But I think you do have to risk stratify people with a history of VTE, morbidly obese, other risk factors, Leiden risk factors, such. I would go with something a little bit more stringent like a Lovenox or even Eliquis.
And then Dr. Tejwani, you're letting people walk. Are you still giving them aspirin for 4 weeks?
Yeah, kind of. I mean, I think that study came out. So, and plus, that's kind of become a protocol now. We give them aspirin. But typically, I stop when they weight bear. So the ones that are weight bearing at 2 weeks, I stop at 2 weeks.
All right, very good. If anybody has any other questions, they can feel free to put them in the chat. If we could pull up the case presentations next, we'll go through a case because I think those are the only big questions that we had. Okay. So we're going to get started on, we'll probably have time for maybe one of these. So case one He's a 58-year-old gentleman. He was a bicyclist struck by a car. He was complaining of bilateral ankle pain. On examination, the left leg had moderate ankle swelling. He was tender to palpation both medially and laterally, and he was neurovascularly intact. On the right side, he had a moderate amount of ankle swelling, more pronounced on the lateral side. And he was tender to palpation both medially and laterally, and he was neuro intact on that side. These are his radiographs. So if we look at the radiographs on both the left and the right, I feel like I'm in the hot seat now. Dr. Konda, what do you see? What are you thinking? Do you want any other advanced imaging for either of these fractures?
All right. So on the left ankle, I see a comminuted distal fibula fracture. It looks to be either at the level of the joint or below. The talus appears to be subluxed, it's like a tilt to the talus, and maybe in a small avulsion fracture of the medial malleolus. I don't see anything on the posterior malleolus. However, there may be something there. On the right side, I see a non-displaced medial malleolus fracture. I do not see a fracture line of the fibula. I don't see anything on the posterior malleolus. I would like to have a CT scan of the left ankle. I don't think I need a CT scan of the right ankle.
All right. Well, ask and thou shall receive. So he gets splinted, and here's your CT.
Okay, this is the comminuted distal fibula fracture. It looks very comminuted. Okay, I did not see anything on the medial malleolus. So, predominantly just a distal fibula fracture, but more than just a distal fibula fracture because we have subluxation of the talus that we saw in the injury film. So there's more of a ligamentous involvement, I think, going on.
Yeah. So what are you thinking for surgery? Are you going to fix both? You're not going to fix the right side? It's not too swollen. It looks like it's amenable for definitive fixation. What are you having with you in the room? Anything special?
Sure. So, so bilateral ankle injuries, and I think I'd like to get the patient mobilized, walking. I think, based on Dr. Tejwani's talk, I think the right ankle, which is the non-displaced medial malleolus fracture, and then my talk on the percutaneous ankle fracture fixation, I probably would do this percutaneous and allow the patient to weight bear immediately on the right ankle. For fixation constructs, 58-year-old male appears to have reasonable bone quality. Probably just do 240 percutaneous cannulated screws on the right ankle. On the left ankle, I'm doing an open reduction of the fibula. It's comminuted. Probably will have some mini fragment fixation options available. I like to use small threaded K wires too for some of these small fragments that may not be amenable to screw fixation. You maybe need something even smaller, like a 1.4 millimeter threaded K wire. I would have suture anchors available. I'm a little concerned about ligamentous ankle stability here, so I like to have some suture anchors available in the room. But that's my setup. I prep both ankles in and plan to fix both at the same time.
Yeah. Anybody else doing anything different? Everybody's definitely fixing the right side. Cool. Okay. All right. So here's where we started. So this was the left ankle. Started on the left-hand side, just like Dr. Konda said. It was a really comminuted fibula fracture. So we did a standard lateral approach to the fibula. And those distal fragments were really small. So I liked to use mini fragment plates. I like mini fragment plates because you can kind of contour them and bend them the way that you want to. On the very distal fibula, there was almost a little avulsion piece. So I used almost a like a tension band or tightrope kind of, like an olecranon construct essentially to fix it. And then an anti-gouted plate on the posterior fragment. And so, like you said, I had a high index of suspicion for ligamentous injury on this side, but a stress examination of the ankle was stable. So this was all that we had to do on this side. And then on the right side, I was thinking the same thing, bam, put 2 screws in, let them start walking on it. But we fixed it with 2 cannulated screws, and then we did a ligamentous exam, and he had significant instability on the lateral side of his ankle. So now what? Dr. Eagle, what are you doing now?
I want to go back. Can you go back to the original injury X-ray
Sure.
on the left side?
Yeah.
I think the reason why the mortise looks kind of funky is I think that the articular surface of the fibular side of the incisura, the articular cartilage on the distal tib fib joint, is broken and flipped in, and that's kind of pushing the talus there. Is that what you found when you got in there?
Yeah. So if you look, I'm going to go back through the CT scan. So that piece was totally flipped around, which is, I think, why it looked unusual.
Yeah.
If you look at, you can see like the perineal groove is like actually like flipped up and on the inside, not where it's supposed to be.
Yeah.
Yeah. So you kind of had
that's
to like
hard to fix because you have to kind of work over the fibula, and then it's really hard to get fixation because you can't get like screws into that piece because if you go through it, you're in the joint.
right.
So I wouldn't have expected a syndesmotic injury because this was all infrasyndesmotic, and the injury of it was really to that articular side of the distal fibula.
Yeah, agreed. It was hard to get to that piece. It took a lot of jiggering, I think, and you kind of had to take down a lot of the soft tissues around the back to kind of re-flip it out to where it was supposed to go. Absolutely, you're right. Let's get back into here. So right side, what are you doing, Dr. Eagle, for the right side?
Yeah, you could do that, and then you can let them weight bears tolerate it in a cam boot. That's a stable injury.
You're not gonna do anything on this lateral side.
No.
No. Anybody else doing anything?
Nope, nothing.
Nothing.
Do we know there's no fibular fracture higher up, correct?
Correct. Yep.
Yeah, then I think you can just watch it.
I would repair the ligaments, Nikki.
Anybody else? Okay.
Yeah, I'm not probably in the boat. I don't like to leave with tail tilt. Although I think Dr. Tejwani and Dr. Eagle are very correct to say also that this is a stable pattern. This is a bad ankle sprain at this point. So you've got a severe ankle sprain. But I think it'd be reasonable to fix it as well.
Yeah. This made me feel
for an
really
ankle
uncomfortable.
scope.
What's that, Dr. Tejwani?
But I said book it for an ankle scope.
Oh, there you go. That's what we really need. Definitely an ankle scope. So I elected to actually repair these ligaments. So when I went in, the CFL and the AITFL were both kind of avulsed off, one on each side. So I repaired it with two cute little suture anchors. So unfortunately, though, because I did a ligament repair, I was worried about letting him weight bear on that side. So he ultimately wound up being non-weight bearing for some period of time on the right. But 6 weeks, he was doing well, and he ultimately went on to heal. He's about a year out. He's walking around very comfortably. Everything has gone very smoothly. So that's our first case. Somebody asked in the chat, this is kind of unrelated, but somebody asked in the chat, I think it's interesting. If you're deciding to do non-operative treatment on a patient, or you know that something's not going to be perfect, how legally, how do you cover yourself? Is there anything that you do if you know that it's not going to be right, to document or do anything like that? Does anyone have any thoughts on that question?
Yeah, I mean these it's most likely these are bad fractures that aren't going to look perfect for the ones I showed. That's where you have a big discussion with the patient and or the family, right? And you document that. That what the expectation is and why you're doing it, and just put it down that everybody was in agreement. That's what I do. All you can do is give people informed consent for an isolated fibula. If someone is really adamant about not having surgery, I'm okay with that. I could treat them in a cast, and I just document it.
Yeah, I think it's all about documentation is key. That's what they say. Okay, cool. So it's about 8:24. I certainly don't want to run over. If there are any last minute pressing questions, they can pop up in the chat in the next minute or so. But otherwise, I'd really like to thank the panelists for taking their time on this Wednesday night to talk to us and teach us about ankle fractures. I think it was a really great conglomerate of talks, and we covered a lot of things. So I really appreciate you guys. I'd like to appreciate everybody for coming. I hope you found it interesting, and see you next time.